digestive system, specifically alimentary canal. This topic, today we have discussed about digestive system, starting from the mouth, oral cavity, pharynx, esophagus, stomach, small and large intestine. In next lecture, we'll talk about accessory organs of digestive system like liver, gallbladder, pancreas, and salivary glands. So, without wasting our time, let's discuss from the very beginning, starting from the mouth. Okay, you can see over here. Our digestive system will start from the mouth, and obviously mouth have two types, vestibule and oral cavity. After the mouth, we'll talk about pharynx. We have three types of pharynx: nasopharynx, oropharynx, and laryngopharynx or hypopharynx. Then after the pharynx, the continuation of the pharynx at the level of C6 or cricoid cartilage, it becomes esophagus. Okay. Then esophagus, after the esophagus, then we have a J-shaped organ called stomach, most widest, dilated and dispensable part of the digestive system. Then after the stomach, we have small intestine. Small intestine have three parts: duodenum, jejunum, and ileum. And after ileum, we have colon or large intestine, having parts cecum, ascending colon, transverse colon, descending colon, sigmoid colon or pelvic colon, then rectum and anal canal. So we will discuss from the mouth. The mouth having two parts, vestibule and oral cavity. Okay, if I can show you, this is our vestibule. See, the external part or anterior part of the vestibule is formed by our lips and our cheeks, or you can say buccinator muscle. An internal or posterior wall of the vestibule is made by our teeth and our gums. So let's discuss vestibule having external part, as I told you, lips and cheeks, and internal part, gums and teeth. And here, just opposite to the second molar teeth, we have a small papilla for the opening of which gland? Parotid gland. Okay. Now we will talk about oral cavity. This is oral cavity present over here, and two parts. One is roof. This is the roof, and then we have floor. Roof is made up of hard palate and soft palate. You can see over here. This is our hard palate. It is present. You can see anterior 2/3 of the floor. Sorry, roof. And we have soft palate posterior 1/3 of the roof. Hard palate is made by two types of bones. I can show you. The hard palate is made up of palatine process of the maxilla and horizontal plate of the palatine bone. And soft palate, you can see over here, it makes the posterior 1/3 of the roof. And in order to check the clinical features of the soft palate, we ask the patient to have, like, say so when the patient will open his or her mouth and say then you can see the elevation of the soft palate and uvula. And if there is any problem, that patient after opening a mouth and saying there is no elevation of the uvula or soft palate, it means there is a tumor or there is a damage of cranial nerve number 11, accessory nerve. So this is a clinical feature in order to assess the credibility and you can say importance and normality of the soft palate. And if we talk about its nervous innervation, the roof of the oral cavity is innervated by trigeminal nerve. Subdivision of trigeminal nerve is second, that is maxillary branch, and maxillary branch subdivided into two parts, nasopalatine and greater palatine. So nasopalatine and greater palatine innervates the roof of the oral cavity. Nasopalatine and greater palatine are branches of maxillary division of trigeminal nerve, that is fifth cranial nerve. So if we talk about the floor of the oral cavity, interior 2/3 is made by our tongue and frenulum. So basically frenulum is just a fold of mucous membrane which holds our tongue, or you can say which anchor our tongue into our mouth. It stabilizes our tongue and it helps in chewing, in speaking. Okay. And in the lateral side of the frenulum, if I can show you over here, at the base of the tongue we have frenulum, which is anchoring the tongue in our mouth, and right and left of the frenulum we have an opening for the salivary gland, sublingual or submandibular glands. Okay, after this oral cavity, after the mouth, let's discuss about tongue. Tongue is a mass of striated muscles. Mass of striated muscles is covered by mucous membrane, and there are two types of muscles which are present within the tongue. One is intrinsic muscles and another are extrinsic muscles. Intrinsic muscles are longitudinal, transverse and vertical. The function of the intrinsic muscle of the tongue is just shape of the tongue, like so. Shape of the tongue is made by intrinsic muscles of the tongue. There are three types: longitudinal, vertical, and transverse. Then we have extrinsic muscles of the tongue. For extrinsic muscles of the tongue, we have a mnemonic called "He pretends stylish and genius." He stands for hyoglossus muscle, or you can see starting from the hyoid bone, inserting at the tongue, hyoglossus muscle. Then we have P for pretend, P for palatoglossus muscle, starts from palatine or palate to the tongue. Then we have stylish, S for styloglossus muscle, starting from the styloid process. You can see over here, we have a styloid process starting from here and going towards the tongue, that is called styloglossus muscle. Then we have G for genius, G for genioglossus muscle, genial tuberosity or a line of mandible to the tongue. So these are four are the extrinsic muscles of the tongue which are helpful for the movement of the tongue. And which muscle is called safety muscle of the tongue?
Genioglossus muscle.
Genioglossus muscle, because the function of the genioglossus muscle is protrusion of the tongue. Like in 2 years old baby love to have play a role of a gin after eating something whose color is very dark red. So while sleeping in our spine position, it's obvious that our tongue will go downward with the help, due to gravity, and it will obstruct our respiratory tract. But genioglossus muscle helps our tongue or protect our respiratory tract, and it will, pull our tongue outward. So it is also called as safety muscle of the tongue. So after the muscles, intrinsic muscles and extrinsic muscles, if there is a bleeding from the mouth, how you will halt the bleeding? You will just compress with your thumb and your index finger just proximal to the bleeding side, or you can say ulcerated or injured side. So after bleeding can be halted after the compression of the tongue proximal to the injury. Obviously you will block the bleeding by compressing the veins and arteries, especially arteries obviously. So after this bleeding, what are the innervation of the tongue? Lingual nerve, it innervates and helps general sensation of the tongue like touch, pain, temperature, vibration, proprioception by lingual nerve, which is a branch of another facial nerve. Then we have chorda tympani nerve, that is responsible for the taste. If we talk about the taste of the tongue, the tip of the tongue having taste for salt, or you can say salty taste. And the lateral aspects of the tongue have sour taste, sour. And middle part of the tongue having taste of sweet. And posterior to the sweet taste we have which taste? Umami. And posterior most side of the tongue having taste for bitter. There is a conflict regarding with this tip of the tongue. In some books it is written that tip of the tongue have sensation for sweet, but many books says the tip of the tongue for salty taste. So it's up to you which book will you follow. Okay, now let's discuss about teeth. Obviously we have two types of teeth, milky teeth and permanent teeth. Milky teeth are also called deciduous teeth. They are 20 in number, and permanent teeth are permanent teeth. They are 32 in number. What is the formula? In order to remember the deciduous teeth, we have 2, 1, 2, 3. It means, if I can show you, if we make maxilla and mandible into 4 divisions, the half of the mandible will be having 2 incisors, 1 canine, 0 premolar and 2 molars. This is the formula for deciduous or milky teeth. Till 6 years of age, we have milky teeth. After the 6 years, we start having permanent teeth. So what is the formula for permanent teeth? 2, 1, 2, 3. Like 2 incisors, 1 canine, 2 premolars and 3 molars. So 2, 1, 2, 3 is the formula in order to remember the number of permanent teeth and number of deciduous teeth, 2, 1, 0, 2. Now let's discuss after the vestibule, after the oral cavity, let's discuss about the pharynx. We have 3 types of pharynx. We have oropharynx over here. We have nasopharynx, we have oropharynx, and we have laryngopharynx or hypopharynx. Let's discuss about nasopharynx. Obviously, pharynx is a funnel-shaped structure. and interior wall of this pharynx is deficient. We know, we can see this is the pharynx. We have posterior wall, we have lateral wall, but interior wall is deficient because of opening of the nose, mouth, and the larynx. So let's discuss from the nasopharynx. Okay. Above, it is present just above to the soft palate. You can see over here, just above. This is the soft palate. This is the hard palate. Just above the soft palate, we have nasopharynx, and nasopharynx just present just behind the nose. Obviously, behind the nose. This is the nose. The roof of the nasopharynx is made by pharyngeal tonsils, and floor of the nasopharynx made by the pharyngeal isthmus and posterior pharyngeal wall, and lateral walls of the oropharynx having opening for eustachian tube or auditory tube. We know in our, okay, if we can remove this thing, suppose here we have our beautiful ear, external ear, then internal ear. Here we have which membrane? Eardrum or tympanic membrane, kaan ka parda. So in here we have a eustachian tube like this. So what is going on? This eustachian tube opening at the nasopharynx. So what is going on? External to the eardrum, we have external ear. So you can say external environment. And internal to the eardrum, we have internal environment. So what is going on? By this opening and by that opening, these are required for the balancing the pressure, internal or external, inside or outside, normally. But what happens when we climb upward in our, while taking off in the aeroplane, we feel something in our ears.
Pressure is imbalanced.
Yes, there is an imbalance of the pressure. We know. So in order to maintain the pressure inside the eardrum and outside the eardrum, there is an opening of the eustachian tube in the nasopharynx. More specifically, lateral walls of the nasopharynx. Now that is why person they ask the passengers to have a chewing gums, just chewing gums. Use chewing gum, and by chewing continuously, then more air will go inside, and your body will try to balance the pressure inside and outside of the tympanic membrane. So okay, let's discuss about oropharynx now. Oropharynx is present just behind the oral cavity or our mouth, and lateral wall of the oropharynx we have palatine tonsils. Roof of the nasopharynx made by pharyngeal tonsils, but lateral wall of the oropharynx have palatine tonsils. Last but not the least, we have hypopharynx or laryngopharynx. Behind, it is present just behind the laryngeal opening, and lateral wall of the laryngeal hypopharynx having cartilage called thyroid cartilage. This is what? Thyroid cartilage. Lateral wall is made by thyroid cartilage, and laryngopharynx or hypopharynx is the most common site for, you can say, lodging of the fish bone. जब हम मछली खाते हैं तो जो हड्डी अटकती है ना, मोस्ट कॉमन साइट कहाँ है उस हड्डी का अटकना? एट द hypopharynx or laryngopharynx. This is the most common site for lodging of fish bone. Okay, now after the pharynx, let's discuss about, we have done with vestibule, oral cavity, tongue, taste, muscles, nasopharynx, oropharynx, laryngopharynx. So laryngopharynx at the level of C6 or cricoid cartilage, it continues to the esophagus. Let's discuss esophagus now. What is esophagus? It is a continuation of the pharynx at the level of C6, cervical vertebra number 6, or cricoid cartilage, and it joins with the cardiac part at the level of T11, thoracic vertebra number 11. And esophagus descends midline behind the trachea. Please remember, if we must have an idea that trachea is present anteriorly and esophagus is present posteriorly, or you can say esophagus is present midline behind the trachea. So there is a mnemonic in order to understand the opening of the diaphragm according to the level of vertebra. Like the mnemonic is I ate 10 eggs at 12 o'clock. What does it mean? Basically 8 stands for T8, 10 stands for T10, and 12 stands for T12. So at the level of T8 there is opening of I for inferior vena cava and there is opening of right phrenic nerve. So at the level of T10 the inferior vena cava or right phrenic nerve will pierce the diaphragm, At the level of T10, esophagus and right cranial nerve number vagus, right? You can see vagus nerve number 10, cranial nerve number 10, that is vagus nerve. That is crossing the diaphragm at the level of T10, plus esophagus also crosses the diaphragm at the level of T10. Then we have at 12. At T12, there is opening of A for aorta and thoracic duct and azygous vein. So these are the, you can see, opening of the diaphragm with regard to the level of thoracic vertebra. Is that clear?
Yes. Yes, sir.
Now let's discuss about the parts of the esophagus. There are basically three parts. The size of the esophagus is 25 centimeter. Okay, and there are other two structures which are having the same length. Other structure is duodenum, a C-shaped part of the small intestine, and ureter, that also having 25 centimeter length. So let's discuss about the parts of the esophagus. First part is cervical part. So total 25 centimeter or 10 inches. The first part of the esophagus, that is cervical part, and length of the cervical part is 4 centimeter and is covered by smooth skeletal muscles, not smooth muscles. This is the only part of the esophagus that is covered by smooth skeletal muscles. You can say they are under your control. Rest of the parts of the esophagus are not purely covered by skeletal muscles. And if we talk about the boundary of the cervical esophagus, it will start from the cricoid cartilage, or you can say inferior of the cricoid cartilage, to the superior part of the manubrial sternum, or you can see over here, it will start from the C6, here we have C6, and here we have cricoid cartilage, and going till superior part, at the level of superior part of the manubrial notch or sternal notch. Here we have cervical esophagus covered by smooth muscles. Smooth or skeletal muscles, very nice. So then we have second part, that is called thoracic part. This is the longest part of the esophagus. Length is 20 centimeter and it is covered by smooth muscles plus skeletal muscles. As I told you, only part of the esophagus is purely covered by skeletal muscle, that is cervical part. Rest of the parts are having skeletal plus smooth muscle, and it starts from the inferior part of the sternal notch towards the esophageal opening into the diaphragm. Okay, esophageal opening to the diaphragm. Then third part, we have abdominal part, which is 1 to 2 centimeter in length, and it is also covered by smooth muscles. And most important thing in abdominal part of the esophagus, that is related to the portosystemic shunt, and starts from the diaphragmatic opening of the esophagus towards the cardiac part of the stomach. And what is portosystemic shunt or anastomosis? I told you that lower part of the esophagus, specifically which part? Abdominal part, having an osmosis of portal system and systemic system. And if there is a portal hypertension or cirrhosis or hepatitis or liver tumor, then there will be rupturing of the esophageal veins, esophageal varices we call it, and the person will have a bloody vomiting called hematomesis. And on there will be you can see the worm-like appearance on the BS. What is BS? Barium study. Barium study. On barium study, you will see worm-like appearance of the esophagus due to the rupturing of the esophageal varices due to the portal hypertension. Okay, let's discuss about constriction. There are 4 constrictions of the esophagus, 4 narrow part of the esophagus. First part is pharyngoesophageal junction. That is the second most narrow part of the alimentary canal. Level of this pharyngoesophageal junction, at name is indicates the junction of the pharynx and esophagus. Over here you can see there is the first constriction over here, junction of pharynx, obviously the hypopharynx or laryngopharynx, and esophagus. This is the first constriction over here called pharyngoesophageal constriction, present at the level of C6 or cricoid cartilage, and it is present at the level of C6, and the distance of this constriction from the upper canines or indices is 6 inches.
So this is the second narrowest part and first narrowest part.
I will tell you later on.
Yes.
So then second constriction, we have aortic constriction. And aortic constriction obviously due to the arc of aorta. There is a narrow part of the esophagus present. It is present at the superior mediastinum and level is T4, and length from the upper incisor teeth is 9 inches. Then third one, we have bronchial constriction due to the passage of the bronchioles, and it is present inferior mediastinum at the level of T6, and the distance from the upper incisor teeth is 11 inches. Then we have, last but not the least, we have diaphragmatic constriction due to the diaphragm. As we know that esophagus crosses the diaphragm at the level of T10. See, at 10 eggs T10 we have opening of esophagus and vagus. So the distance from the upper incisor teeth is 15 inches. That is very important for the NG tube passing. And so if you are trying to pass the NG tube, nasogastric tube, in a patient in a medical or surgical emergency, you must not forget the length of the tube. So it must be, as far as adult is concerned, it is varies from person to person also. So at least when you insert that tube with 15 inches, then you are at the last part of the esophagus, or you can say you are at the diaphragmatic constriction of the esophagus, and then you will just more descend your tube, then you will be in the stomach. Okay. Now we will discuss some clinical features related to the esophagus. First of all, Barrett's esophagus. There is a conversion of simple squamous epithelium of the esophagus towards the columnar epithelium. That is also called dysplasia. And the causes of this Barrett's esophagus is smoking and gastric reflex. When there is a gastric reflex upward, the acid will go upward, and in order to maintain the stress of that acid in the esophagus, there is a natural phenomenon that for simple squamous epithelium will convert into columnar epithelium. As we know, these stomach is wall made up of columnar epithelium. You will learn these epithelium, columnar, squamous, stratified in histology. But right now just remember, the epithelium of the esophagus is simple squamous. But due to acid reflux or smoking, the simple squamous epithelium of the esophagus converts into columnar epithelium. That is called Barrett's esophagus. And if you treat the GERD, gastroesophageal reflux disease, or you quit smoking, then this columnar epithelium will again go backward toward the simple squamous epithelium. But if you can't quit the smoking, or you are unable to treat the GERD, then this dysplasia will lead to anaplasia, or you can say it will cause the esophageal cancer. Then after the Barrett's esophagus, we have esophageal varices. We have discussed that the most third part or abdominal part of the esophagus having a portosystemic anosmosis, and due to portal hypertension or cirrhosis or hepatitis, there will be backward flow of the portal veins, and there will be rupturing. There are more chances of rupture of the esophageal veins called esophageal varices, and due to rupturing of the vein, there is a bleeding from the mouth, obviously hematomesis. And on barium study, you will see the worm-like shadow on barium study. And third, we have achalasia cardia. What happens? This is the cardiac part, and here we have cardiac sphincter. And if there is congenitally absence of inner nerves which are required to opening of this valve, or there is any other pathology in which there is the person is unable to open this cardiac sphincter, then what will happen? It will behave like this. It will be like this. So this is called achalasia cardia, in which we have bird beak appearance on X-ray. And then fourth one, we have a tracheoesophageal fistula. If there is there is a close proximity of the trachea and the esophagus, then there will be formation of a fistula over here. Fistula. And whatever you will eat will go towards our lungs, to the windpipe. So that is the tracheoesophageal fistula. Fistula is abnormal opening. So abnormal opening between trachea and esophagus. Whatever you will eat or you will drink, not only it will go to the esophagus, but will go to our lungs. And you will have choking, or you may have aspirational pneumonia. And last but not the least, we can have dysphagia, difficult swallowing or eating, due to two causes. Number one is left atrial hypertrophy, because the location of the left atrium of the heart is just anterior to the esophagus, and if there is hypertrophy in the left atrium, it will obstruct obviously the esophagus, and there will be difficulty in eating or swallowing. And then we have mediastinal syndrome, which can also compress our esophagus. It will lead to the dysphagia. Now after the esophagus, let's discuss about stomach. in Latin we call it gastro, gastroenterology, gastritis. Gastro means belly, and this is the most dilated, most wide and most distensible part of the digestive system. And it is having two locations, vertical and horizontal. Vertical location of the esophagus present in tall, thin persons like you. Yes. And horizontal position of the stomach occurs present in broad and highly active persons. Yes. And due to the vertical position, it is J-shaped organ, you can say. So if we talk about the capacity of the stomach, we know there are three types of capacities: in newly born, in adults, and in puberty. In newly born, the capacity of the stomach is 30 ml, 30 milliliter. And in puberty, we have 1000 ml capacity of the stomach. And in the adulthood, we have 1500 milliliter capacity of the stomach. So after the capacity, we have gastric pain. Due to the dermatome from C6, C7, C8 and C9, we will have epigastric pain, because as I told you, we know the level of Nichols is T4 and level of umbilicus is T10. So dermatome of the stomach is C6, C7, C8, C9. So if there is any problem to the stomach, it will lead to the epigastric pain, and due to that dermatome we can have a chest pain also, which is also called heartburn. You may be listening somewhere, the person is having heartburn. There is nothing to do with the heart. That is pathology of stomach only. When you give some PPIs or some drugs which relieve the gastric insult, then you may relieve the heartburn also. Now then there is two opening of the stomach. Okay, you can see there is one opening over here called cardiac opening, and then one opening over here called pyloric openings. Pyloric opening. Obviously we have pyloric sphincter and cardiac sphincter over here. So if we talk about the parts of the stomach, we have 9 parts. First part of the stomach called cardiac part. Here we have cardiac. This is cardiac part. Okay, cardiac part of the stomach. This is the most fixed part of the stomach. It is present 2.5 centimeter left to the umbilicus. 2.5 centimeter left to the umbilicus, and it is covered by 7th costal cartilage. You can see over here. 1, 2, 3, 4, 5, 6 and 7. So left 7 costal cartilage is covering what? Cardiac part of the stomach, and is present 2.5 centimeter left to the midline. Sorry, not umbilicus. 2.5 centimeter left to the midline. And then second part is fundus. That is a dome-shaped part. And it is always filled with our swallowed air while eating, while speaking. We also swallow some air also in our stomach. So that air that we swallowed, that will store in our fundal part. That is why on X-ray we will show some bubble. That is physiology. On X-ray, on chest X-ray, if you see some bubbles under the left diaphragm, that is normal. That is physiology. But unfortunately, if you can see the bubbles at the right, under the right diaphragm, that is pathology. So fundus, dome-shaped part, covered or filled with air swallowed, and is projected upward. You can see over here, it's projecting upward. Then we have probes space. It is present overlying the fundus, and there will be tympanic sound on percussion. When you percuss overlie the fundus, you will have a tympanic sound. After percussion we have many sounds like box sound, dull sound. So tympanic sound can be heard. Then we have body of the stomach. Before we discuss the body, the size of the stomach is 6 centimeter and 6 inches and 9 inches, almost 25 centimeter. So body is the largest part of the stomach, and start from fundus to the notch. Here we have a notch, this one, that is called gastric notch, or incisura angularis. Starting from the fungus to the incisura angularis, we have body. Then after the body we have pyloric part. Pyloric part in 2 parts, pyloric antrum and pyloric canal. First part is pyloric antrum, then we have pyloric canal, and it is made by thickened sphincters. That is very much required in order to have a normal flow of gastric content in the stomach. Then after the pyloric part we have pits, gastric pits required for the gastric opening, for the gastric glands. Gastric gland opening we have pits. Then we have gastric folds also, or rigoi formation, the mucus folds present at the empty stomach, not in a filled stomach. That will increase the surface area of the stomach. Then last but not the least, we have lesser curvature and greater curvature. Lesser curvature is the shorter, it is concave, it is making the right border, obviously the anterior border of the stomach, and it is connected with the liver with the lesser omentum. You can see over here, this is the lesser curvature. It is concave, making the right border, anterior border. It is connecting with the liver with the lesser omentum, and this is this part of the stomach which bears maximum insult are beared by lesser curvature. If you drink too hot or too cold, or if you intake the alcohol, that will disrupt our lesser curvature. And we talk about greater curvature. Obviously it is a lesser curvature was shorter, greater curvature will be longer. It was concave, then greater curvature is convex. It is making the right border, the greater curvature is making the left border. So it is connected with the liver with the lesser momentum, but greater momentum by this lower part connect with the transverse colon by greater momentum, and is connecting by this part to the spleen called gastrosplenic momentum. And there is a mnemonic for the gastric ulcers. The persons who are vulnerable to having gastric ulcer, the person who are in hurry, mostly worry, and love to have a spicy curry. It means the person who are in a hurry, trying to do many things in no time, and who are always in depressed condition or are worried, or who love to have a spicy curry, spicy food. They are vulnerable to have gastric ulcer because that will increase the so the spicy curry is very, as much as you intake the spice, that will increase the production of acid. It will cause the acidity, and we have with worry means stress. So we have stress-induced ulcers also. In ancient times, we say constipation is the mother of all disease, but now we are saying that stress is the mother of all disorders. So now let's discuss about. Okay, I can show you the alcohol, the hot coffee or a hot drink, or a cold or ice cold things will insult the lesser curvature. Okay. Now let's discuss about gastric bed. Gastric bed is made by, there is a mnemonic called Dr. S3 kills patient mercilessly. These are the content which are making the bed of the stomach. D for diaphragm, S for splenic artery, splenic flexure, K for kidney, and S for suprarenal gland also. S3 means 3S. S for splenic artery, splenic flexure, and suprarenal gland. Obviously the left suprarenal gland. K for kidney, obviously the left kidney. Then P for pancreas, and M for mesocolon, transverse colon. These things are making the bed of the stomach. They are separated from the stomach by lesser curvature, except spleen, which is separated by the greater set. All the content: diaphragm, splenic artery, splenic flexure, left suprarenal gland, left kidney, pancreas, and mesocolon are separated from the stomach by lesser sac, but only the spleen is separated from the stomach by the greater sac. Let's discuss after the stomach. Let's discuss about small intestine. So you can see over here, basically we have done with the oral cavity, vestibule, oral cavity, nasopharynx, oropharynx, laryngopharynx, esophagus, stomach. Now we are at this part: duodenum, then jejunum, then ileum, then colon. So first of all, duodenum. Small intestine starts from the pyloric part to the ileocecal wall. Duodenum, it is a C-shaped part, and it curves around the head of the pancreas. It curves around the, if this is the curve of the duodenum, and here we have a head of pancreas lying like this. So head present over here. So it is just like curve of the duodenum around the head of the pancreas. That is also called organ of romance. And it is a C-shaped, most widest part, and size. What is the size of duodenum? 25 centimeters. We have discussed esophagus, duodenum, and ureter have 25 centimeter length. Then there are few parts of the duodenum. First part or superior part, which is present at the level of L1 vertebra. Length of the superior part of the duodenum is 2 inches, and first 2.5 centimeter of the duodenum, it's making a cap, or you can say it is also called duodenal cap. It makes a triangular shadow, and it is the most mobile part, and most ulcers, gastric ulcers, peptic ulcers occurs in the first part, and bleeding because in posterior wall of the first part of the duodenum having passage for the duodenal artery, posterior gastroduodenal artery. So the first part will have a maximum ulcer side, obviously gastric ulcers or peptic ulcer, and most bleeding side due to the rupture of the gastroduodenal artery. And then we have second part or descending part. This is the second part or descending part. This is present at the level of L2. Length is 3 inches and it's just a sandwich between the superior mesenteric artery and abdominal aorta. And this is also a transverse part which is crossing the, you can see, okay, not, we have descending part, sorry. Second part is not a sandwich, not a transverse crossing. Second part is present at the level of L2, 3 inches long, and with the distance of 1.9 centimeter, there is major duodenal papilla and lesser duodenal papilla. You can see this is the major duodenal papilla, lesser duodenal papilla, and the length between these two papillae are 1.9 centimeter. And these are the papillas, like greater duodenal papilla will get the secretion from the hepatopancreatic duct, common bile duct, and lesser duodenal papilla will get opening of the main accessory pancreatic duct. So the second part of the duodenum, it gets secretion from the common bile duct, from the pancreas, from the liver. Okay. And third part is also called inferior part. This is the third part or inferior part. Is present at the level of L3. Length is 3 inches. This is the sandwich between the superior mesenteric artery and abdominal aorta. And is it you can say it transverse part which is crossing the T3 level. See, it's crossing. In fourth part, it is also called ascending part. This is the fourth part or ascending part. And there is no pharynx. This is also present at the level. Okay, this is present at the level of L1. This is present at the level of L2, and it is also present at the level of L3. And fourth part is also present at the level of L2. So L2 having two parts of duodenum, second part and fourth part. And the fourth part, that is also called ascending part, which connects with the ligament of traitz, which is connecting with the right crus of the diaphragm. And this is the ligament which distinguishes the upper GIT bleeding from the lower GIT bleeding. If there is any problem which is causing the hematomesis, that is upper GIT bleeding, which is obvious that if someone is having hematomesis or blood in vomiting, that is upper GIT bleeding, there is a problem proximal to the ligament of traitz. If person is having bleeding feces called melena, it means it is a lower GIT bleeding. The problem of pathology must be distal to the ligament of traitz from here to here. So fourth part, that is the ligament of traitz, which is attaching with the right crus of the diaphragm for the anchoring of that ligament and anchoring of these abdominal content, and this distinguishes the upper and lower GIT bleeding. Obviously, upper GIT bleeding, hallmark of upper GIT bleeding is hematomesis, and hallmark of lower GIT bleeding is melena. Now let's discuss about after duodenum, jejunum and ileum. We have studied about jejunum and ileum in compare and contrast concept. So these are few features. Then feature of jejunum and ileum. If we talk about this length, the total length of the jejunum and ileum is 20 feet. And if we talk about the length of the jejunum, that is 2/5 of the intestine, is 8 feet. And if we talk about the length of the ileum, that is 3/5 of the intestine, that is 12 feet. If we talk about the color, jejunum is deep red in color, but ileum is pink in color. If we talk about the location, jejunum is present left upper quadrant of the intestine, and ileum is present right lower quadrant of the intestine. If we talk about the vascularity, the jejunum is highly vascular or having greater vascularity, and ileum having lesser vascularity. Vasa recta is long in jejunum and short in ileum. Fat in mesentery is present abundantly in jejunum and present sparse condition or very less amount in ileum. Wall of the jejunum is thick and heavy, and wall of the ileum is thin and light. Pairs patches are very few in jejunum but very largest and numerous in ileum. If we talk about the plica circularis, which is a circular fold that are tall, larger and closely packed in jejunum, and low, sparse and distally present in the ileum. So these are some differences between jejunum and ileum, which are part of the small intestine. If we talk about difference between the small intestine and large intestine, small intestine is mobile except the duodenum, but large intestine is fixed except the ascending colon and descending colon. Small intestine having mesentery, but large intestine is a retroperitoneal organ. except the transverse colon and sigmoid colon. What are the retroperitoneal organs? As I told you about the peritoneum, about liver, gallbladder and pancreas, we will talk about in next lecture. There is a mnemonic for the retroperitoneal organ called sad puckers. We will discuss about this mnemonic in our next lecture. Right now, just understand that mesentery, there is a, in small intestine we have mesentery, but large intestine is a retroperitoneal except transverse or sigmoid colon. Diameter of the small intestine is smaller, as the name indicates small intestine, and diameter of the large intestine is larger. That is what is also called large intestine, because this is all about due to diameter which distinguish small and large, not according to the length, because small intestine is larger in length and large intestine is smaller in length. But we call it small intestine because it's having small diameter. We call it large intestine because it's having larger diameter. If we talk about the fatty tag, which is absent in small intestine, but for the large intestine we have appendices, epiploiky. Then the muscles in small intestine we have longitudinal muscles throughout the small intestine. But in large intestine we have tinea coli, which are 3 bands of narrow longitudinal muscle present all the colon except appendix, cecum, except appendix, rectum and anal canal. Then wall of the small intestine is smooth, but wall of the large intestine is sacculated or hostration. That makes the puckered appearance of the large intestine. There are few internal differences of the small and large intestine. Plica circularis is present in small intestine, absent in large intestine. Pairs patches are present in small intestine, but large intestine we have solitary, separated lymph nodes. Villi are present in small intestine, but villi are absent in large intestine. So now after this differentiation, let's discuss about large intestine in detail. Large intestine starts from the ileocecal junction, small intestine starting from this part, pyloric part or pyloric sphincter, and ends at ileocecal junction. But large intestine starts from the ileocecal junction till the anal canal. So you can see large intestine starts from the ileocecal junction to the anus. The length of the large intestine is 5 feet or 1.5 meter. You can see there is a small intestine is larger, but we call it small because having smaller diameter. So according to diameter we name it large intestine or small intestine. Large intestine having tinea coli. Okay, as I told you, these are the 3 narrow bands of longitudinal muscles which covers all the large intestine except appendix and rectum and anal canal. Then we have appendices, epiploiky, that is a sac, a peritoneal sac of fat which cover all the colon except the appendix, rectum and anal canal. And that is why in between these epiploica appendices we have sacculated or hostration of the large intestine that makes the appearance of this large intestine called puckered appearance due to the hostration. These are the hostrations that makes its puckered position. So after this, let's discuss about part of the large intestine. First part is cecum. You can see over here. You can see the width is 3 inches and the length is 2.5 inches. So there are total 3 parts in our body which is having width more than their length. One is cecum, other is pituitary gland, and third one is our prostate gland. In cecum, there is a blind-ended pouch, and in infants it is funnel shape, and appendix is present at the apex of this funnel, but in adults appendix present postero-inferiorly. And it is a target part for the intestinal TB, for amoebic dysentery, for cancer, and inflammation of the cecum called cystitis or typhlitis. And then we have ascending colon. You can see over here. Ascending colon is shortest part of the colon, 15 centimeter. And about 10% of the cases ascending colon having mesentery. Then we have transverse colon, that is the longest part, about 50 centimeter in length. Longest part, and this is the most mobile part, and it crosses with the flexures. You can see here we have a hepatic flexure. This is due to liver presence over here. We have a liver. This flexure, this band is called hepatic flexure. Due to presence of spleen over here, this is called splenic flexure. Splenic flexure is more acute. It is costodiaphragmatic ligament is attaching with our diaphragm also. So it is a little bit higher or superior to the hepatic flexure also. Then let's discuss about descending colon. This part, the length of the descending colon is 25 centimeter. 25 centimeter. And this is there are two parts, proximal part and distal part. And then the fifth part called sigmoid colon or pelvic colon. This one, the length is 40 centimeter, and this is the most narrow diameter part, most narrow part of the large intestine. 40 centimeter length, most narrow part, and starts from the iliac fossa to the S3, and is the most common site for volvulus. If you talk about the site of the sigmoid colon, starts from the iliac fossa going towards the S3, from here to here, not from here to here, until unless there is any exception. Exceptions are always there, but majority of the people or population start from the sigmoid colon, start from the iliac fossa towards the S3. But if there is a problem like Carter-Jenner syndrome or situs inversus, where all the organs are opposite, from the iliac fossa to the S3, go backward. In Carter-Jenner syndrome or situs inversus, the organs are just opposite. Normally we have heart on the left side, but in that patient we have dextrocardia, right-sided heart. Stomach is present at left side, but stomach will be present at right side in that patient. So sigmoid colon present over here from the iliac fossa to the S3, but in that patient we have sigmoid at the right side. So it is called Carter-Jenner syndrome, situs inversus. That is an exception. Now we are talking about normal things first. So starting from iliac fossa to the S3, and is most common site of volvulus. What is volvulus? You can see the this sigmoid colon will go like this, volvulus. This is the most common site is sigmoid colon, pelvic colon. Then there is a CA or cancer of the sigmoid colon will lead to intestinal obstruction. And in colonoscopy, we can directly see the whole colon. So whole colon is visible. We can say direct visibility of the colon can be seen by colonoscopy. And what is written over here? Mid-gut. We have three types of gut, right? How many guts we have?
Three.
What are the names? We have hind gut, mid gut, and third gut. We have. What is the name of that third gut? Four gut. Four gut, mid gut, and hind gut. Four gut starts from upper side till the ligament of traitz. Then we have mid gut, start from the ligament traitz toward the, or you can say 2/3 and 1/3 of transverse colon. Here, from here to here we have mid gut. From here to the anal canal we have hind gut. This is you will study in embryology. So these were about large intestine. Let's discuss about Meckel's diverticulum first. What is diverticulum? This is the evagination of the mucous membrane, and if there is inflammation of that evagination, simple evagination of this mucous membrane of this intestine, that is called diverticulum. And if there is inflammation to that evagination, it is called diverticulitis. We have Meckel's diverticulitis present over here. In order to remember the Meckel's diverticulitis, we should remember the rule of two. What is the rule of two? Tell me. What is the rule of two for Meckel's diverticulum? Number one rule of two, it is, you can say it is 2 inches long. Rule of two means 2 inches long. It is 2 feet away from the end point of the ileum, or 2 foot proximal to the ileocecal junction. Then it is present 2% of population. Then it is present 2 times more in males, and it is having 2 types of tissues. One is gastric tissue and one is pancreatic tissue. The rule of two, in order to remember the Meckel's diverticulitis. Then we have, last but not the least, our favorite worm-like, finger-like projection from the posteromedial side of the cecum called appendix. It is a finger-like or worm-like projection that is 6 to 9 centimeter in length, but present 2 inches below the ileocecal junction. Suppose here we have ileocecal junction. The length of the appendix is 6 to 9 centimeter, and it is present just below to ileocecal junction. Distance is 2 inches. And it is also known as abdominal tonsils, because in many books it is written that it acts as a lymphoid follicle. That is, it is also called abdominal tonsil. And there is a valve present over here called valve of Gerlach. And we have valve over here also called ileocecal junction. That is, relaxed by our gastrin. We will study about these enzymes in physiology. So valve of Gerlach is covering the appendix, and is due to the lymphoid follicle characteristic feature is also called abdominal tonsil. Okay, there is a location of the most common location of the appendix is retrocecal, behind the cecum. Most common site is retrocecal. If the appendix is present or starts or present at the posterior side of the cecum, and unfortunately the appendix is inflamed, then on extension of the hip joint you will have a pain. That is called SOS sign positive. And if the appendix is at the pelvic side, normally you will not have pain. Not only extension, not only internal rotation. But if this appendix is at our retrocecal position, then on extension you will have pain. That is called SOS sign. And if this appendix is at present over here like this in the pelvic side, and then there is inflamed appendix present at the pelvic side, then on internal rotation you will feel pain. That is called obturator sign. So these are the two signs. So not only these two signs are required for the proper diagnosis. For the proper diagnosis of appendicitis, we have Alvarado MANTRELS score. Then MANTRELS, MAN, the first three are the symptoms. Then TRE are the signs. Then LS are the lab work. What's the difference between symptom and sign?
सर जो पेशेंट बताए वो
The complaints, which are complaints of the patient that he or she will, he will tell to the doctor that called symptoms. Like a person telling I am having fever,
observation is
yes. If the patient is telling I have abdominal pain or headache or vomiting or a diarrhea or a weakness, that are the symptoms. And doctor's observation, like he will check the signs or some other, he will use his skills, that will be the signs. So what are the symptoms according to MANTRELS? M stands for migration. The pain will migrate. The person will, if on asking, he will tell you, yes, doctor, the pain is migrating from here to here, from here to here, from here to here. That is migration. Simple. A for anorexia, loss of appetite. Then you will ask the patient, do you have dinner? He will say, I don't want to. I'm not feeling hungry. So that is called anorexia, loss of appetite. And third symptom is N for nausea, pre-vomiting condition, matli. The person will say, I'm just about to have a vomiting. That are the three symptoms the patient will tell you. What are the doctor's observation? T for tenderness. Normally you will feel no tenderness, but in an appendicitis patient, on touching, on pressing, you will feel a tenderness, cord-like rigidity, like this, tenderness. Then we have R for rebound tenderness, Rovsing sign. Then E for elevated temperature. And then when you put a thermometer, and you will have a temperature more than 99.9 degree Fahrenheit. And what are the lab things? L for leukocyte count. There will be elevated of TLC, total leukocyte count or differential leukocytes or WBCs, more than 10,000 per millimeter cube. Then as for shift of leukocytes, means you can say the neutrophils should be more than 75%. So there are the few score or MANTRELS scores. Okay, we have McBurney point also. If you draw a line from anterior superior iliac spine to the umbilicus and medial 2/3 of this line, we have a McBurney point where you will have a incision for the appendectomy. So is there anything I left? Colonoscopy, you can directly see the whole colon. You can see colonoscopy helps for the direct visibility of the colon. So that was about today's class.
Yes.
Alimentary canal starting from mouth to the anal canal. We talk about the rectum. Okay, after sigmoid colon we have rectum. You can say storage point for the feces. When there is a large amount of feces at the rectum, that will create an urge to defecate. And we have two types of sphincters in the anal canal: internal sphincter and external sphincters. Internal sphincters are covered by our smooth muscles, and external sphincters are made by skeletal muscles. You can say the internal sphincters are not under our control, and external sphincters are under control, but not in our kids. When we are very old, 1 to 2 years, we are unable to control our external sphincters also. So whenever there is a pressure in the rectum, the baby will leak out. But now you have, fortunately, you have control over your external anus sphincter. So in spite of immense amount of pressure over here, you can control, because external sphincter is made from skeletal muscles, and skeletal muscles are under our control. But again, in our old age, we will lose the control on our external anus sphincter. So nature is the master creator. So these things we have discussed in detail about. Is there any question?
No, sir.
Okay, thank you so much.